Hey, I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. Hey listeners, I value you being here. Please, I encourage you to leave a review. I'm going to be reading out a review each month, and that person can have a one-on-one call with me to have a chat. And I think that is a great way to reward you as a listener. Also, as you like and subscribe to this podcast, it helps get our message out to other physicians and clinicians who are struggling. Thank you so much for your reviews, and I look forward to reading them out here on the podcast. Hello, everybody, and welcome back. We have another wonderful episode ahead. We have Dr. Diane Sliwka with us, who I'm going to let you introduce yourself. Welcome.
Hi, thanks for having me. So my name is Diane Sliwka. I am Chief Physician Experience Officer at University of California, San Francisco Health. I am a professor of medicine in the Division of Hospital Medicine, and clinically I practice as a hospitalist. And I have a little side project working on life coaching for midlife professionals as well.
Wonderful. Excellent. Tell us a bit about your journey. What attracted you to being a hospitalist and how did it go?
Hospitalist. Well, let's see. I guess my journey started back when I was little, 4, and I wanted to be something kind of superficial. I was telling my dad I want to be a model or something, and he said, well, that'll only last you for some years or something. You should do something like be a doctor. And he planted that seed for me when I was really quite small. And I think as I grew up, I found myself wanting to learn and spend my life learning and do something that was really valuable for people. And this seemed like the most noble profession. I think hospital medicine attracted me because I really like breath and I really like the cognitive part of medicine and the thinking part of medicine. Hospital medicine was broad enough, but also had the appeal of you could do critical care and you could focus your career in certain niche areas and specialize in a way. And you could stay in academics and be an educator also. And I think all of those things really appealed to me without having to go through more years of training and fellowship and things like that.
Got it. Okay. All right. How did it go? How was residency? How was your journey?
My journey, well, I think I'm a journey person. So I think from early on, I've accepted that the whole pathway of becoming a doctor was going to be a process and a journey, and that I had to love it as I went. So that was always the frame of mind I had about it. So I think compared to maybe a lot of colleagues I know, I never had the feeling of I'm missing out on something. I felt this is my experience. It's not the same as other people my age, but it is a cool experience nonetheless. And that I think helped me a lot in training because training is very, very difficult and was very, very difficult at times. I think my experience as I got into post training became a little bit different. And I think as I entered into being an attending and saying, okay, what's the next thing that happens in my what's the next goal? I found myself looking for what is that next thing going to be. And I think when you get to being an attending, there isn't a very obvious next step. So that was one interesting part of the pathway. And then a few years in, I landed in a job where I found myself really struggling actually in just the demand, I think, of the job at the time and really experiencing my own version of what now I think a lot of people understand to be burnout.
Yeah, okay. That doesn't sound so good. Can you tell us some of the workflow or themes that were contributing to some of that difficulty or challenge?
Yeah, I think what is most memorable to me is just the number of hours on end that we worked and the days on end that we worked and how that was just this Groundhog Day every day. You just get up, you'd go in, you'd work for 12 hours, but then the commute was a couple hours, and then you just have enough time to sleep and maybe eat a peanut butter and jelly sandwich, get up and do it again, and day after day after day. And the number of weekends I worked, there was just not enough rest. There was not enough of your other life. And I don't care what your job is, like it just at that time, I remember there were probably 8 or 10 people who started in the job I was starting in the same kind of class, I guess I call it now. And almost all of them left in that year. And I was watching one by one just basically quit or leave or find something else or find another place to go. And I was, what is going on here? It's not just me. It's easy to kind of just feel I'm not enough to do this job, but it was very clear to me that there was just a problem with the system and how our jobs were set up at that time.
Yeah, yeah. That's a long commute. And I suspect that's pretty common if it's going to be a city-centered kind of placement.
Yeah, I happened to be in San Francisco, which I'm calling it door to door. An hour probably wasn't quite that bad, but all in all, there's just very little time to just decompress.
Yeah. I think that's really important for people to hear because I've heard that before that when you add the commute to the shift, especially if the shift is spilling over with incomplete work or tasks, then it just takes out so much of the day.
Oh, yes. I didn't even mention that. So thank you for saying that because just the nights of this is such a strong memory of just going home and falling asleep with your computer in your lap and just typing the notes and trying to just do the documentation and waking up the next morning with it not finished because you fell asleep while you were doing it again. I mean, like we're talking the hours in the hospital, but then the work was never quite done while you were in the hospital. It had to be finished at home as well. So yes. You're bringing back a lot of bad memories.
Yeah. As a group, did you discuss this and how you might solve it for yourselves? If there were, 12 of you that started, no, 8, you said started.
Yeah, I think maybe like 8. We talked about it a lot. We probably vented to each other a lot. I think at that time, we also probably tried to speak up about it. I remember, but we were so junior at that time that I don't think I remember not feeling like I had any say or power to say anything. And I think we were also so junior that you feel like you're trying to make an impression, you're trying to build your career, you're trying to figure out how you're going to make a place for yourself in this new place. And I think it's really hard to speak up at that time. But I have this one memory of a leader of a clinical service at that time, telling us to just document less. We're doing too good of a job. Like if we're going home and writing notes for so long and stuff, just try to do less of it. Maybe you're just spending too much time. And I think what he meant was actually probably right. But the way it came across was don't do as high quality of a job as you're doing in order to decrease your burnout. And I was like, doesn't feel right, either to me. And I think that was the problem is I think you go into medicine and you're so conscientious and have such a strong ethic around helping people and doing the job well that you feel like you have to do all this detail-oriented extra work. And so much of that is self-inflicted, but also just the nature, I think, of the work we do. Like if you mess up, it actually impacts people in a very serious way. So
yeah. What was the solve for that? Was there a change? Was there a move to a different location? What did you find solved?
Yeah. Well, I think this is a cool part of my personal story, but it's certainly not what I would expect everyone to do. But I ended up staying in that job. I ended up luckily somehow over time, getting into leadership roles in that job and being in more of a position of being able to actually decide or certainly influence what was happening. I do remember early on at that point, kind of what actually happened was when all the people started to leave, I think there was a recognition of the problem that became very obvious and then resulted in a lot of attention to what was happening. And so For example, I remember retreats for the entire division started to be focused on well-being, started to be focused on what can we do to make our structures better. Okay, we have 14-day stretches of work. Can we decrease them to 7-day stretches of work? Can we decrease the shift length a little bit? Can we have flexibility in a swing person so that the swing shift allows for the evening person to leave a little bit earlier, not at 7 p.m., but at 5 p.m.? All of a sudden, I think because there was this exodus of people, there was this attention to, oh, this is actually something that we can fix and solve. And those things started to happen. But being able to eventually, when I was in positions of running clinical services and things, I just remember being able to sit there and say, why are we designing this service like this? Like we could design this differently in a way that makes it work better for people. And, most of us, I mean, I don't care what age you are, you have a life to live, like regardless of whether you're young and with a family or not. But at that time, in hospital medicine, many people, because it's such a new field, were in the young family side of things. And that is a particularly vulnerable time, I think, for the time demands on you outside of work. So there was a groundswell from the people, and also just a recognition, I think, from the leadership that we're all coming together at the same time.
Yeah, that's a good end to that story. Well, not necessarily an end, but a good way of showing how it could have been, or how it could have been resolved for some others who are struggling in this area as well, because this is a common thread we see. These big, long shifts, long days of service. The work's not done when you get home necessarily. Yeah, so much to think about. And interesting that you took a leadership role. How did that add to your expectations on the job?
Well, it's interesting. Every time I've been confronted with something, a new opportunity that, sounds good, but you're also sitting there being, I am too tired. How can I even do anything else? It's funny because I've almost said no to lots and lots of things, and then recognized that saying yes to things that change the work is a very positive thing. So luckily, I didn't get so bogged down in the burnout piece to say no to things that actually turned out to be very, very helpful to me. But I think taking on leadership roles shifts. You still have so much work to do and demand, and often need to be on and available in very different ways at all times, especially in clinical operations. But it certainly changes the nature of the work, and I think started me into pathways of finding things I loved, finding meaning in the work in ways that I was able to influence improvements that I thought were helpful for the job, the career. And those things are an antidote, I think, often to the burnout. And in some ways, leadership creates more flexibility. Clinical work is incredibly, incredibly inflexible, I think. And, if we were to do something as a field to improve burnout, like the flexibility piece is one piece. I think that's hard not to crack, but is something that, like, if you can find ways in your job to create more flexibility, that is such an antidote, I think, to burnout as well.
Interesting. Okay, so just having different interests even within work. Yeah.
Yeah, for me, that has been kind of a secret power of just crafting your job to be. I think we get so fixated on, I'm a doctor and there's just this one pathway and I can't even give up being any part of that because I've been working so hard to be this thing. And yet, like, being a doctor sets you up also to have a Venn diagram of adjacent roles that may be actually speaking to your heart much, much more loudly. And it's not that you have to completely give up being a doctor, but starting to shape your job and craft your job into something that has more of that meaningfulness. Or, not to say that doctoring isn't meaningful to me. I actually thought that one-on-one care of patients, educating trainees was incredibly meaningful. But there's something about newness and novelty and variety in your work that also sparks, I think, your energy and uses your brain in different ways that can really help your job feel whole and much more rewarding.
Interesting. Yeah.
Yeah.
Tell us about, you said academia interested you, trainees interested you. Was that part of within your hospitalist work, or where did that come in?
Yeah, my first jobs were in academia. I was in Boston for a little bit at Beth Israel Deaconess at the Harvard system, and then moved over to UCSF. And I don't know, something about coming out of academia left me wanting to stay in academia. I think there was the part of wanting to be around a learning environment, keep learning, keeping around education. I actually did an education fellowship for a year in Boston. And all of that was very appealing to me. I think just intellectually stimulating, generally speaking, and felt like it would be the kind of career that I wanted.
Mm-hmm. Yeah. Tell us about the wellness project that you're involved in now.
Do you mean my wellness work so my chief wellness officer work?
Yeah.
Yeah, let me start with that. So back in maybe 2014, at that time I was directing patient experience at UCSF, and my job was to work with physicians on improving the patient experience, and it was a health system role. I was focusing on communication, how physicians and providers communicate with patients. And I would walk around and go to all these physician work meetings, faculty meetings, and get up in front of people and show them their patient experience data and try to get them really excited about being better for their patients. And I just remember that presentation after presentation after presentation, people would just look at me like I was crazy because they were sitting there having the experience I had been having several years before, where they were just, you've got to be joking. I don't have any time to do anything else than what I'm already doing. Somebody needs to focus on my experience. And I just kept getting that message over and over. And I was super junior at that time still, even though I was in this leadership role, I was still finding my way. And so I remember saying to my boss, we need to measure this. People are telling us this, and there's a problem here. And burnout had just started to be really publicly talked about in the literature, and it was kind of new. Some people were doing it, like Mayo Clinic had been doing it for a while, but for most of the country, it was new. And so I remember at the time my boss said, it looks really bad for us to focus on something that's not patients. He was just kind of, we shouldn't be so self-focused. We need to focus on patients. But by 2014, he okayed me to survey our physicians. And so I home grew a survey at that time to make it cost effective and stuff. And we started producing data about how the physicians felt at our organization. And lo and behold, it wasn't a surprise to me because I had been in front of, these were my colleagues. I had experienced it. I was in front of them every day. But was interesting was that to the administration and to leadership that was not clinical, the data showing how unhappy people were about the work experience was very new and very eye-opening. And so all of a sudden, it got the attention of people in leadership who oversaw operations, who oversaw how things were structured a little more visibly. And that blew up my career, I will say, in terms of, in a positive way. It basically created all of this work to do to figure out how do we address this problem. And at that time, again, there wasn't a roadmap for this. People hadn't quite figured it out. There wasn't, now we have millions of articles about how can organizations make the workplace better. But at that time, we were, maybe we should put in a doctor's lounge, and maybe we should, we were just, what could we do? And so I think over years, what happened was a little bit of trial and error, but mostly just looking at that data and listening to what the comments were telling us and the richness of what that story was. And just slowly starting to figure out, okay, what can we do? And slowly starting to take those steps. And now I'm like 10 years, more than 10 years into it now. And it's an ongoing journey because there's new problems. We didn't expect there to be a pandemic, and we didn't expect there to be the current administration, and we didn't expect all of these reverberations of what is happening now. So it's an ongoing project of watching the data, listening to people, and then where possible, doing whatever we can as an organization to change the systems and culture that support the people that do the work. And maybe I'll pause there. There's so much more to say, but I think that really became the focus of my work.
Yeah, yeah. To hear that there is organizations, leadership, administration listening to the people on the ground saying, you want me to what? Don't you understand my experience? I'm not having a good time here, and actually wanting to do something positive about it. Can you go through some of the things that you implemented out of that research, whether it be at the beginning or since?
Yeah. Well, I think there are some really concrete examples, large and small. I will say there was one point at which our organization had the largest employment of human scribes in the country because we were trying to help the documentation burden problem. And at that time we didn't. So now we have AI scribes, which is transforming documentation in a real concrete way without increasing labor cost. But for a while we were hiring people to help our people with their documentation time. That was huge. Not enough. Definitely wasn't helping enough. But now with AI scribes coming on board, we have made that open to all of our ambulatory physicians, all of our advanced practice providers. And that is really helping people in a data reported way on with their burnout. In basket, so for ambulatory providers, the way we provide care to patients has completely transformed over the last decade. But the way we value provider time or reimburse that time doesn't take any of that after hours in basket time into account mostly. And so finding ways to make that work more streamlined, reimbursable to some degree at least, and as efficient as possible for people so that they're not spending for every hour they see a patient multiple hours doing charting and in-basket related work. Those are probably two of the massive parts of work that are very difficult, particularly for outpatient providers. But then there are other things for people who have parts of their work that include meetings. I remember after the pandemic, we had back-to-back meetings and everyone would just get on Zoom from 7 o'clock in the morning till 6 o'clock at night, maybe. And so we kind of did a whole system revamp around creating 5 to 10 minute standard breaks between meetings. So our meetings start at 5 after the hour if they're half-hour meetings, or 10 after the hour if they're hour-long meetings, and just completely making that a standard across the organization so that there's space for everybody to just breathe a little bit. And what usually happens is probably people just use that time for continuing their meetings. But it's a cultural transformation by creating a structure essentially that forces breaks. And those are just a few examples, but there are thousands of examples. And I think the reason there are thousands of examples is because probably what has been most effective is getting leaders across the organization to care about the data in a way that they all think about their field of oversight, their scope of what they can do. And everyone is constantly doing this continuous improvement evaluation of how can I make the work better? How can I solve the thing that I work on? And if you're working in the medical staff office and credentialing, you're helping support how we change the med staff application language about mental health so that people don't have to report historical mental health problems that are no longer active, or maybe they have active mental health problems, but they're treated and they're not impacting patients. So that person's helping work on something that is supporting people from a mental health standpoint, perhaps, even though they're a med staff person. And maybe the person who, works in campus services is working on right now, one of our leaves got updated to include bereavement for reproductive loss. So for so many years, when I had my miscarriage with my child, I literally left my shift, walked over to a clinic, got told that my 10-week-old baby was no longer alive, and then walked back to shift, finished the shift, and never took a day off. And that's just how we did it. Now we're okay, this is a loss. This should be part of leave, and we make that official. And so every part of the organization is now, I think, at least at UCSF, to me, aware of the problem, aware of the value of solving the problem, and thinking about what is my part in this? What do I advocate for? How do I make this better? And that's not to say that everything's solved. You will walk around our organization and people are still very, very upset, very, very burnt out. But there is so much happening at all times that is trying to make the situation better. And I have to think that at least some of that reaches people, different people for different initiatives, different, I think, amounts that it is helping people. But I definitely feel like we have built something that is now structured in a way that it doesn't need me around every day to make it happen, because enough people care about it to keep it moving forward.
Yeah, yeah. We hear so often that if we could be asked the question, what do you need to be successful today? And somebody listened and tried to assist in that request, that it would make our day so much more sustainable or easier. And I
Yeah.
think that's what I'm hearing from this organization is you're really asking the workers to ask for what do you need? And you're asking that question from different layers and trying to meet those needs where possible, which I think is very interesting and a good amount of flex and maturity for an institution and an organization to have brought in.
Thanks. Yeah, I think you're so right. For people to be able to articulate what they need, but the caveat to that is people have to articulate what they need in a way that people can hear them, because sometimes the articulating what people need comes across as something else. It comes across in a way people can't hear it and get shut down. Even leadership, I think, now that I see both, I sit in the middle. I sit with one foot in the leadership space and one foot in the frontline space, and I can watch how leadership gets overwhelmed and shut down if the asks are come across as, I call it violent sometimes, like people screaming or accusing or demanding. Or it's not that we shouldn't be upset. We should be upset, because being upset creates that motivation for change. But also we have to remember the humans that are in the system also have their own limits of things, and how do we say things in a way that it can be heard and processed and taken and something done with it? That is sometimes hard.
Mm-hmm. Yeah, be interesting to hear how you hear those requests then. What is the method for asking for what you need? Is it
Yeah.
an email? Is it going to a meeting? Is it having a having a corridor wine? I don't know.
Yeah, I like to think that most organizations now are asking for feedback in the format of anonymous surveys, which is probably one very easy way to provide your organization with feedback. And then I think if I would want to give advice to myself as a frontline person who needs something, I think remembering to see the perspective of the person I'm talking to, like while I'm also sharing my perspective, helps again for the message to get across and land with people. Because I think when I was junior, I didn't know what I didn't know about why certain things were the way they were. Like, why do we structure it this way? Like, is there a reason? And maybe there is a very good reason. And that informs what can be done and like what is possible. And I think helps people get into a place of listening to you when you actually are showing interest in like, how did we get to doing this? And is anyone open to listening to doing something different, and trying to figure out like, who are the allies? Who are the people who actually do care and like want to do something? Because not everyone is in the place of being able to help you make it right, but plenty of people are. So
Mm,
finding those people. Mm-hmm.
yeah. As a physician or clinician engages in the system, say after a period of leave or with a new disability, for a better word, is there a way for them to be able to express what they're going to need to be able to be successfully returned into a workplace? How, not through like a work cover, but more just I'm going to need a standing desk. I'm going to need extra breaks here. Is that something that's addressed? Because anonymous surveys may not pick those sorts of things up.
Oh, that's a great question. Well, I'm sure this is organization dependent and
Of course, yes.
and the best situation would be if those concerns were heard and accommodated. And, I know technically speaking that organizations have disability departments, they have accommodations. I think what we know from our own data is that those accommodations and don't always necessarily meet the need that people have. And our organization has tried to do some work on that, but I'm sure there is so much more to do, and certainly that is an I think, probably served area of the workforce need that could use more attention.
Fair enough. Tell us more about the inbox and
Mhm.
novel ways or interesting ways that that's been remunerated. Because we hear across the country, the burden of the inbox has really blown out of the water since but COVID, or just before COVID, we started having a lot more email, work lists, patient direct to clinician physician kind of interfacing, physician to physician speak inside the hospital system with instant messaging and other ways to interrupt your specialists. And the burden must be so much bigger than we ever expected it to get to. Tell us more about what was happening around your parts for that.
Yeah. I will say that we knew this was a problem many years before we actually started tackling it as a problem, which makes me sad, but it took a while to, I think, start working on this in earnest. We were very lucky that we had leadership in our ambulatory world that cared a lot about this interest of how do we take care of our people. One of the things that helped was we created an organizational goal. So our leaders across the system get incentivized to make certain things happen in the organization. And one year we decided to take this on, the in basket, and align leadership essentially around all working on it. So whether you were executive leadership or a medical director or practice manager, people got all into the same aligned goal, basically. And part of your salary was going to be actually dependent on this happening. And so again, using data, like realizing how many messages go direct to our providers, physicians or advanced practice providers. Like if you were a restaurant and your customer walked in and wanted to be seated and you expected your chef to seat your customers, your chef would not be cooking the food and you would not have a high quality restaurant. And this is like in medicine. Once the electronic medical record came out, we didn't really pay attention to the fact that the chef was seating the customers. Like the doctors were suddenly receiving all of the messages. Wasn't a screening process. There wasn't a triage process. So if someone was writing about how do I get to the office or my billing or, any question that may or may not actually require medical advice that a physician would answer, that would go straight to the physician. And that became a massive, massive problem, let alone that some of the care was starting to happen in the in-basket. So, and not paid for, not accounted for. So people would work their full day job at the brick and mortar building and then also have all this care that they were providing electronically to patients, which is where we want to get to, but how can you get there if you don't actually create time for that work to happen? So I think we started a whole process around what are the different parts of this that could be improved upon. Routing of messages to physicians versus to a team. Okay, so let's start with that. Let's move from the baseline 70% are going straight to physicians. Let's get that down to like 40% going straight to physicians and make sure the things going straight to physicians are the actual messages that you need a physician to answer, like something is changing about my medical problem and I need medical advice. So that routing, the triage, using the electronic medical record to automatically triage certain things where patients can click, what is this message about? That was the beginning of triage through a little bit of electronic help. Now we are moving into an age where AI will probably help us to triage that even better than it's been triaged. Once we have a team that's getting the messages, we found something else was a problem. So if the team doesn't know what to do with that message, it just gets passed right back to the physician. So you've actually added someone else doing work, but you haven't taken away anything. The physician's just getting the messages right back. So training the staff, algorithms creation that are specific for your specialty that help that message actually get handled without needing the physician. Very, very helpful. Clinical decision support that happens within the record, like for prescription refills, like where now the EMR gives you very specific, like if you're going to refill a blood pressure medicine, it tells you have the labs been checked in the last year? What do we need to do? Do we need to see the patient? Like there's all this stuff that automatically comes up that just saves time, that allows people to do that clinical work faster. And then valuing, so making medical advice a billable encounter, or helping creating a way that people, if the medical advice actually needs a visit, making that into a video visit or making that into an in-person visit if needed. And then so much work around the team functioning of that. Because again, you need a team supporting all of that work. Like it's really hard to do that with just one person managing all of it. So how do those teams get feedback and operate in a way that is respectful of everyone's role? People are working top of license, but also know what is my part in making this work happen and taking care of patients? That's probably an oversimplification of it, but I think those are the kinds of things that have been worked on. Every year we've seen more progress in all of that. It's still not, again, you could walk around here and find lots of people who are still struggling, but I think the combination of all those things, plus now the scribing support, is really putting a palpable dent in people's work experience that we had not had, up until a couple of years ago.
Yeah. Do you see that there's provision within the workday for that inbox work?
Not as much as we'd like yet. It's on the list of things that we have been talking about. I bet there are some systems that have done this. We haven't done this. Everyone gets a day of administrative work if you work in an ambulatory setting, for example, where in-basket is the biggest problem. But that's not enough. I think actually one of the things that I would like to see us do is to say, this is a way we now deliver care, and this is part of the workday instead of something that's happening after hours or between the work. That to me feels the right answer, because the future vision of healthcare environment we all want as patients is I want to be able to get that care from my doctor that I don't have to go in for over the message. Like that would be so much better for me as a patient. That would be so much better for many patients. If we don't create a system that supports that, then it's not just about the workforce struggling. It's also not helping us get the future state of healthcare that would make healthcare better in general.
Yeah. It's a way of improving access, but you're right. There's so much things that we need to think about with regards to who's getting that message. I like hearing the maturity in the system, that there's somebody looks at this before it goes straight to the physician or clinician's inbox. Such a improvement over how many physicians are still working within this system.
Yeah. And I think it just took a really long time for people to recognize, and this is the disconnect between the front line and I think people who are leading operations a lot of the time, is if you're not putting those two people together, groups together, then it just goes unrecognized for too long. And I just think it went for way too long in healthcare until it became the burnout kind of crisis that we're in now.
Yeah. There's still systems being rolled out that had this already inherently a problem, and it wasn't just as it's rolled out, which, wow.
Yeah.
So much work to be done, but I'm glad to hear that there's some maturity in the system and you can go and make some changes, make some noise for what you need, and see what can be happening around your place, which is really important. Thank you so much for this conversation. Is there anything we didn't talk about that you'd like to let us know about?
Let me think. I think the work of doctoring is such a beautiful, noble profession. And I think if we can, again, within the system in which we work, which is currently probably not optimal, if we can find ways to help ourselves like really just stay and thrive and feel really happy, we can get to careers that feel really sustainable and not burning us out. And being part of, once you can create that space a little bit, I think you can become part of the solution of the system instead of just drowning in it, which is what I think many people feel like they're doing right now. And if you're the drowning person, it can't be your job to solve the problem. So we need people who've kind of found their way to space in their jobs to actually solve the problem. So I think depending on where you are in the system, there's a way to play a part in all of this. But I feel very heartened that we're moving in a direction in healthcare that feels like it's actually moving the needle.
Love it. Very good. How do people reach out, find you if they're interested in learning more about what you're doing in the world?
Sure. I have a LinkedIn, an Instagram account, an email. I don't know. Will you include those in the?
We'll have some of them in the show notes. I just thought if
Okay.
there's a website or somewhere you'd like us to be able to just check you out.
Yeah, let's see. I think if you look up my name, honestly, there are a number of sites that you'll find me on and different things that I'm involved in. But I'd be very, very happy to hear from people. I love talking about this work and would be very happy to connect.
Excellent. Thank you so much for this conversation. Have a wonderful week, everybody. Bye. Hey, if you found this podcast episode helpful, I would encourage you to like and subscribe. Every time you do, you help a colleague or friend find our podcast and it can help them too. Don't forget to share it along with your friends. If you're looking for extra help, don't forget we have charting champions for physicians and smarter charting for nurse practitioners and other clinicians to help you get home with your work done. We are helping you create sustainable clinical medicine.